everyone, and welcome to today's Healthcare Provider Program, Navigating Your Young Breast Cancer Patients' Emotional Health. We're so happy you could be here with us today. My name is Stephanie Washburn, and I'm the Manager of Healthcare Provider Outreach at Living Beyond Breast Cancer, or LBBC. I'm pleased to serve as your moderator today. This program is part of LBBC's Young Women's Initiative, which provides resources tailored to meet the specific needs of women diagnosed with breast cancer before the age of 45. The Young Women's Initiative began in 2011 when we were awarded a cooperative agreement with the Centers for Disease Control and Prevention to expand and strengthen our programs for young women. This CDC funding continues today. A focus of the Young Women's Initiative is engagement and education of clinical and lay navigators, as well as other providers, about the unique needs of young women impacted by breast cancer. Because of this, we're so pleased to have partnered with the National Navigation Roundtable to bring you today's program. The National Navigation Roundtable, a national coalition of over 50 member organizations and individuals, is dedicated to achieving health equity and access to quality care across the cancer continuum through effective patient navigation. I'd like to thank the many people at the National Navigation Roundtable who helped make this program possible. We selected today's topic because of its importance to young women with breast cancer and the essential role played by navigators and other healthcare providers in helping young breast cancer patients manage the unique psychosocial and emotional challenges they face, many of which have been compounded by the pandemic. I would like to thank our speakers, Zarek Mena and Celeste Vaughn Briggs, for sharing their time and expertise on these important topics. You'll learn more about Zarek and Celeste shortly. Now, let's move on to a few final details before the presentation. Today, we'll be using the chat feature to connect with you and share information during the program. You'll see the chat icon at the bottom of your screen. We'll be using the Q&A feature too, which is also located at the bottom of your screen. Please submit questions for our experts throughout the program. We ask that you frame your questions in a general way so they can be helpful to all participants. Select questions will be addressed during the Q&A session. Please remember to use the Q&A, not the chat, to submit questions to our speakers. For participants who would like to use closed captioning, you can select this feature by clicking the up arrow button next to closed caption on the bottom of your screen. Then click Show Subtitles to start displaying the captions. We will be emailing you a link to our program evaluation today. Your feedback is very important to us in planning future healthcare provider programs, and we appreciate you taking the time to complete the evaluation. While we are not able to offer continuing education credits for this program, certificates of participation will be available upon request through the evaluation process. Evaluations must be completed by September 29th, and certificates of participation will be emailed by October 20th. I would also like to note that our speakers and planning committee members report no conflicts of interest for this educational activity. The speakers' views do not necessarily represent those of the National Navigation Roundtable, LBBC, or the Centers for Disease Control and Prevention. We are recording the session and will post it soon on lbbc.org. We will notify you via email when the recording is available. It will also be added to the National Navigation Roundtable website. In addition to the recording, we will be sharing featured resources that we hope will be helpful to you. It's now my pleasure to introduce our expert speakers. Zarek Mena, certified oncology patient navigator, has 15 years of experience in the field of patient navigation, survivorship viewpoint, and local navigation network leadership. Zarek was instrumental in the creation of the Smilo Family Breast Health Center and Memorial Sloan Kettering Cancer Center Physicians Affiliation at Whittingham Cancer Center at New Vance Health, including its numerous support programs. She currently serves as Women's Health Program Manager bringing the Commission on Cancer and National Accreditation Program for Breast Centers accreditation standards to the next level. Zarek facilitates the Academy of Oncology Nurse and Patient Navigators, Fairfield County, Connecticut Patient Navigation Network. Her passion for serving underrepresented and historically excluded communities has led Zarek to implement local programs such as cancer screening through the Connecticut Early Detection and Prevention Program. Celeste Vaughn Briggs, licensed clinical social worker, has more than 25 years of social work experience and now serves as manager of the Free Breast and Cervical Cancer Screening Program at Thomas Jefferson University's Sidney Kimmel Cancer Center in Philadelphia. The program serves several hundred people with diverse backgrounds each year. Celeste provides vital navigation and psychosocial support to these women and men throughout their course of treatment. She is also a member of LVBC's Medical Advisory Board. Celeste is an adjunct faculty member for the Temple University School of Social Work and was previously with the Jefferson Community Health Worker Program. A lifelong resident of Philadelphia, Celeste earned her undergraduate degree in psychology from Temple University and her Master of Social Work from the University of Pennsylvania. We're grateful to Zarek and Celeste for sharing their knowledge about supporting young women with breast cancer and are honored to have them with us today. Thank you so much, Zarek and Celeste, for joining us. And I will now turn the presentation over to you.
Welcome, everyone.
Welcome, everyone, while we wait for our slides here. Welcome. Today we'll be discussing navigating young breast cancer patients' emotional health. Next slide.
Just one second. Thank you so much for your patience. I know we're all used to kind of some Zoom technical difficulties, but we will be getting started shortly. We're really excited to present on this topic and wish we even had more time because there's so many aspects to touch on as far as young women and their emotional health, navigating a cancer journey. So thank you again. Next slide.
Now, we'll review our learning objectives. Navigators who participate in the program will gain knowledge of unique issues faced by young women with breast cancer, early stage and metastatic, including the impact of the pandemic, emotional topics most frequently voiced as issues of concern by young women with breast cancer, signs of emotional health concerns related to breast cancer and the pandemic, barriers, including those related to health equity, which may impact the emotional health of young women with breast cancer, tools and resources to support the emotional health of young women with breast cancer. Next slide.
So these are some of the issues that are of concern. Young women often voice several of these different areas as being very important in terms of their cancer journey, places where they experience distress around, areas that are important to them. So briefly going to go through these. So as far as fertility, there are concerns that young women face when faced with a cancer diagnosis that are unique versus versus older persons who may be past their childbearing years. So this is a concern that often doesn't get screened enough, but that young patients want to know what their options are in terms of fertility preservation and what potential long-term impacts of treatments are. For our breast cancer patients, issues of self-image and sexuality as they are younger are of particular concern. These are obviously concerns that can be out throughout the life cycle, but being a young person faced with a body altering surgery and potential impacts on sexual health throughout their lifespan, looking forward 20, 30, 40 years may be of particular concern. The impacts to relationships, intimate partnerships, and that goes for persons of all different sexual orientations, for heterosexual couples as well as same-sex couples, the impact of cancer treatments, the cancer journey, and any other concerns along the way. Young women find themselves as part of what we've heard of, right, the sandwich generation. Those who are caring for and parenting younger persons, as well as being faced with caregiving for elders. And these are particular concerns that young women may find themselves working through, having issues and barriers present themselves that we as navigators, social workers, nurses, physicians, all aspects of the cancer care team that are surrounding these patients may need to be aware of. There may be particular employment-related concerns. As we all know, most individuals in the United States obtain their health insurance, which pays for treatment through their employer. So concerns that may be specific to that may be key for young women who are facing a breast cancer diagnosis. And along with that, with employment-related concerns, obviously are discrimination concerns, whether that be through the, employment discrimination or other facets of discrimination that may impact all aspects of that person's psychosocial experience based on their race, their gender, their sexual orientation. Something that's not unique to young cancer patients is true, unfortunately, for most cancer patients, are the concerns surrounding financial toxicity. Cancer treatment is expensive, and not just the treatment itself, but all of the ancillary issues that come up that we just discussed, which are concerns of the young women: childcare, elder care, lost time from work, impacts on insurance. Those are very significant barriers and concerns that young patients bring to us. And last but not least, barriers around language or limited English proficiency, as well as health literacy, which is one we don't often think about. We may be very nuanced and sophisticated and have an understanding of all these health and health-related terms because we work in the field. But those who are just coming to this experience, this is a whole new language, and it may feel very overwhelming and prompt feelings of distress. So we need to be aware of that. Next slide, please. So for our concerns for patients who have metastatic breast cancer, there can be additional barriers that present themselves. The grief and loss of future roles, disconnect from peer groups, and other cancer patients who may be early stage may have curative intent, which can be further isolating. There could be some additional barriers, financial barriers that are age specific. For example, someone who has been diagnosed de novo or have a recurrence and are young and have a metastatic breast cancer diagnosis, while there may be many more treatments, the trajectory of care and the length of care can be a concern. It may be one thing to kind of rally our resources and pool financial or other supports for that period of time. But if it's a long-term, 5, 8, 10, potential even longer time frame, that can be very concerning. Advanced care directives and goals of care discussions can prompt feelings of anxiety, distress, worry. While they are necessary, they may be unique concerns. And there certainly can be some healthcare bias or healthcare provider inequity in terms of treatment options or other treatment that is presented to them, or support and resources. I know, Zarek, if you want to add anything to that.
They had a little bit of technical difficulty, but thank you. Yes, I believe you're on the metastatic breast cancer slide. And my drive home point here is that, as we know, breast cancer is diagnosed in metastatic breast cancer at all ages, including young, and their support and their navigation is particular in the sense that it has these nuances that we have to be sensitive to. Of course, that's the case with all populations, but in this particular case, we have chronic and we have long-term decisions to be made oftentimes, and it's an ever-evolving checking in on these population and making sure that this ever-evolving changes are being addressed.
Thank you. Excellent. So I want to hone in. We're going to talk a little bit about what are some of the specific challenges that emerged throughout the COVID-19 pandemic. There were obviously, as with other areas of healthcare and mental health care, there were existing fissures or concerns or disparities that impacted a cancer patient's journey, no matter what age, but specific to young patients. We found that there were specific, because of shutdowns and because of disruptions all along the cancer care continuum, from inpatient care to outpatient visits to imaging to radiology to medical oncology, that there could be these coordination gaps. People who were used to having services all in one pace, live, face-to-face, some things were happening through Zoom. And that may have presented additional challenges, which can amplify anxiety and concern because it's the unknown. And we as providers experienced that, and patients experienced it also at the same time of having the unknown about what their cancer journey was going to look like. So again, existing issues were exacerbated, particularly that some of our cancer care exists in silos, that sometimes transitions of care are difficult and things may get lost. Folks may not have smooth transitions from one aspect of the care team to the other, and the pandemic certainly exacerbated that, as well as risk assessments, risk calculations being different for different people. Folks who may be used to having their school-age children in school were now trying to juggle healthcare appointments and online school and decision-making about the children's health and their health. So all of these different aspects did lead to some increases in anxiety, depression, and other mental health diagnoses that impact treatment.
We're going to do a closer look into food insecurity. Let's say a deep dive. A study published in August 2019 issue of Journal of Cancer Survivorship revealed that approximately 8% of 1,022 cancer survivors who participated in the National Health and Nutrition Examination Surveys experienced food security, with higher rates among some groups, including survivors who were uninsured, young survivors, parents with children at home, Hispanics, or Blacks. And so Celeste and I are going to share a case that we work on, and we have discussed on a family that in fact faced food insecurity. And I just want to preface with saying I had a clinician once tell me eons ago how cancer and is just a slice of the pie. You know, there is a larger pie and a whole life and a whole dynamics and experiences behind each individual and their families. And we are only able to work on this now diagnosis and how can we help that. And the pandemic only exacerbated some of these. So if there were if financial issues, food insecurity, work, family dynamics, and things that were happening, oftentimes we found that the pandemic only exacerbated that, and we had to be really creative in figuring this out. Uh, I was deeply affected by a scenario in our center, the previous slide still, please, where we were faced with a 36-year-old Haitian woman that had language barriers, financial barriers, work, 2 children. And in fact, she had all the support services around her to help her through her diagnosis. As she was sitting in her chemo chair with her cold cap on, her son was hoarding food from the pantry. And what this did was, as we were observing, was identifying food insecurity. In fact, when we asked them, you know, what their plans were for the evening, it turns out that there was no food in the home. So I had to be very creative in figuring out means in which to do this. And so many services were at a halt during the pandemic. And we were able to tap into a mutual aid group. I worked very closely with them to help feed our community as well as cancer patients. Moving forward into the program, when I brought this to our administrators and our social work and nurse navigator, and again, being at the table, being able to have these discussions made all the difference, and being in that unique position as a navigator, and in my case, a non-clinical navigator, to have the support and be mentored by my peers was really that piece that allowed us to bridge the gap. We looked at how we were providing the food and how can we best sustain this program. Ultimately, we were then faced, unfortunately, with the death of George Floyd and addressing systemic racism in our country. And we went ahead and looked again at our program. We ended up changing the program to gift cards. And we realized that we were not doing charity care, it was solidarity. It was not taking away their identity and their family dynamics and their heritage at the dinner table, which is where all of these traditions and customs and our routine happens. We were respecting it. So there's a continuous need for us to respect our community, look at our practices, and figure out how to be the best navigators. This was a success for us in a unique way in which we were able to address this young breast cancer patient during the pandemic. And I want to tell you, although it sounds quite complicated, please contact me offline. I'm happy to tell you how we created the program in our center. And ultimately, I will tell you that it was the goodwill of the community, and that when we asked and we had definitive numbers, we were able to address it. So, so no, it's not impossible. It does take some legwork, but it is a worthy reason, and a lot of the kind of good work that social work and navigation is able to do once well supported by your administrators and your clinicians. Next slide.
So I wanted to bring up some facts and figures that the American Cancer Society is looking into about all different impacts of the COVID-19 pandemic on cancer care, both at the front door, through treatment, and again into post-survivorship, and some concerns that the American Cancer Society, clinicians, other accrediting organizations, persons in all aspects helping cancer patients share their concerns. So there, obviously, as we just illuminated, there were shutdowns. There were reduced numbers of inpatient and potential outpatient services. There was a shutdown in cancer screening in many different locations across the country. And what did that do? That impacted prevention and early detection. Some of the concerns that are laid out in this special section report that's available on the American Cancer Society's website, and the citation is below. There are concerns about moving forward, the impacts on late diagnosis, later stage diagnosis, which we know impacts survival, mortality, morbidity, fewer treatment options, or treatment options that may be a little bit more narrow. We certainly are concerned with the impact, long-term impact on cancer mortality, and there are many different groups looking at this. Next slide, please. This study, which was also very interesting, and the citation is below, looked at not just the United States, but this was done by ASCO and in conjunction with the WHO, the World Health Organization, to look across the globe what were some of the different impacts of the COVID-19 pandemic on cancer care. And in this analysis, they found 38 different categories of disruption, which is huge. And yes, they point out in the article, some of this is kind of apples to orange comparisons, because while there are national, international, and global, kind of standards of care for oncology treatment, different countries may have different systems in which they operate, different supports surrounding patients, different availability of different treatments, et cetera. But that these categories were still significant and concerning. There were disruptions across the board in inpatient and outpatient services, canceled or delayed surgeries, impacts to chemotherapy treatment, as well as radiation treatment, follow-up imaging, et cetera. And the rescheduling or cancellation of these visits were impactful. As we know, much of oncology care does happen in an outpatient setting, specifically around breast cancer. This study looked at all cancers. So there are some cancers, obviously, that have a larger inpatient component. There is a long-term longitudinal study. Most of you may know that the American Cancer Society has a CPS-3 study, which is looking at a cohort of individuals, and they did a lot of work to try to recruit folks from different racial, ethnic, geographic backgrounds, and they are adding questions to their study, their cancer prevention study around COVID-19, and to try to track those individuals who are also in the study if they have been infected by COVID-19 and kind of what the impacts are long-term. So stay tuned for that. Next slide, please.
In the Journal of Oncology Navigation Survivorship, there was a paper on the need for complete cancer care team that's critical as we move out of the pandemic. This was in May of 2021. And it can show that we have significant volume of newly diagnosed patients, as well as more patients with advanced disease. Our oncology navigators and social workers are essential to managing both their care and supporting the influx of patients, as well as addressing the social inequities existing in our community. Revenue and expenses will be impacted if we don't have streamlined and efficient care organization. So as Celeste just mentioned, we have this trend of influx and needs. And in fact, navigators and social workers are key to controlling these costs, such as these no-shows and these readmissions, these cancellations, and not adherence to treatment planning. It's also going to be very difficult to reassemble the navigation team. So as it relates to the pandemic, evidence exists that trying to cut staff and then bring them back can actually be more costly. So it's very important to sustain your program as well as prove your worth with metrics. And the way we do that is to make a difference, to reduce these no-shows and readmissions, cancellations, follow these metrics that allow us to give the best care to our patients. As you know, navigation has been proved to address cancer disparities at its core evidence-based strategy, specifically to address health inequities across racial and ethnic minority populations. So even in a high stress time now, during the pandemic, during Delta, and as we're trying to figure it out, we are uniquely positioned as social work and navigators to build community trust into our health systems and to move the needle on cancer outcome disparities. Navigation is a critical tool in this toolbox, and we need to make sure that we're working all to the top of our field and that we're able to bring value not only to our institutions and our community, but ultimately to the lives of our patients. Next slide.
With health disparities, I'm sorry about that feedback. So one thing that we've kind of a thread that's been woven in what we've talked about is that we all want the best for our patients, but we also acknowledge that there are differences and disparities. What are cancer disparities? I'm probably preaching to the choir, and you guys know about this, but they are measurable differences in cancer outcomes among various population groups. This data was started to be collected through SEER in 1973, and we have demonstrated over many, many decades that these differences are significant in terms of incidence, prevalence, stage at diagnosis, morbidity, and mortality, which is very concerning. There have been lots of great programs, interventions in ways that navigators, social workers, nurses, oncologists, health systems, community-based organizations do try to address these. So I don't want it to seem like it's no hope or that things are exactly the same as they were as these disparities were first being identified, studied, and categorized. But we still have to acknowledge that these disparities exist. And part of that awareness allows us to be sensitive to who is the person in front of us, what are the different identities that they bring to their cancer experience, their age, their race, their ethnic background, their immigration status. Are they from a particular part of the country? Is this an urban setting or rural setting? What about sexual orientation and the biases that healthcare providers may have in society in general? And how does that impact the treatment? Young women also face some additional barriers and disparity again, and we talked about that at the beginning of the presentation around fertility preservation. Unfortunately, it's still not as uniform as it could be across the country about letting young patients know about their fertility preservation options. So we want to keep that into our mind as a takeaway.
Navigators and social workers can provide valuable referrals, emotional support, and linkage to internal and external resources in this area that makes a huge impact in the care of young women with breast cancer. So Celeste, let's go back to our very kind woman that had some food insecurity there. So when I first met her, and I just want to show you the dynamics between us, and again, many of you are social work and navigators on the line, but for those that are patients or administrators, physicians, those that are joining us from the general public, please understand the impact that we can make and that we're here. In this particular patient, I was contacted by a clinic system that just couldn't figure out how to qualify her or get her compliant to recommendations for imaging, but that they knew something was wrong. And so I reached out and I made that personal connection. And as I'm building this relationship and realizing how many things we need to address, I had to get creative. And I reached out to the Haitian Association, which was able to pair me up with a nurse that was in the community, someone that can speak the language. So although we use all the proper resources built within the system, like a language line and such, it's it behooves us to think outside the box and figure out how we can get those resources in order to there to be compliance and for there to build trust. It's a two-way street, so it benefits everyone. Now this association knows that we're here and that we're here for their community and that we are willing to make these connections and go to these extents that I don't believe they had these connections prior. So now future referrals are coming in and identification of people's services. But once I identified her, I had to bring her to some resources, right? To the resource that would help me solve the problem. And here's where Celeste would be able to help us.
So where this would happen would be if I got this referral from Zarek and from the community group, we would, I managed the uninsured women's program. So we would see, could we qualify her for the CDC's program, BSEP, Breast and Cervical Cancer Education Detection Program. Different states may also have renamed or have different names for their program. Some institutions have additional philanthropy funding to try to help individuals who are uninsured, who are in need of screening or diagnostic imaging and other services to identify a potential cancer and getting them navigated in. So in this instance, I would bring her in. I would have her seen by a clinician, have a clinical breast exam that is covered under the program, get the imaging and biopsy leading to a cancer diagnosis. Most of these programs go from initial point of contact through final diagnosis at no cost to the patient. So that would be a key factor to reduce stress, anxiety, and worry, and to address a potential disparity in equity about access to care. And many of these programs, such as mine, part of our responsibility does not end just at diagnosis. It's also with connecting to the care team, which includes obtaining insurance or other mechanism to obtain so that the patient can get the cancer treatment that they need. So kind of working together from outside resources to getting connected internal in the system and then following that patient and then kind of putting on our other hats. Some of these programs, such as mine, we wear dual hats. So I am an oncology social worker, a licensed clinical social worker. So then can work with the care team all along their cancer trajectory. And they knew me from the kind of getting in the door, which helps to reduce worry, helps build trust in the community, and then kind of linking back to our community navigators so that they may be introduced to me and maybe there may be other opportunities for referrals for other persons who may be uninsured in the community, and working with the whole team, the navigators, the social workers, in connecting these resources and reducing disparities.
It's a big feat for our financial navigation team to work on as well. Many institutions do not have a formal financial navigation in place, although this work is happening oftentimes on site or within the institution. So we do look at, again, just like Celeste stated, within the institution for charity care or insurance options and such, but definitely financial toxicity and financial concerns are something we're addressing as navigators throughout the continuum of care.
Next slide. So the impact of stress and bias and inequity, I think we've talked about it. It's really across the board. These disparities and inequities can be around social economic status, educational level, certainly region of the country, because we know there are kind of embedded disparities. Some patients have to travel significant distances to actually access care, and that can be a barrier in and of itself. That's we, as part of the team surrounding that patient, to help them with. And One thing I want to hone in on, both Zarek and I, of becoming an effective advocate in addressing issues can be a key step in improving care. And this is where we can help address those emotional concerns, because it is very, very apparent. Worry about things not going well can sometimes even have folks retreat, isolate, or not connect to the treatment team in the way they need to.
I agree with you, Celeste. Becoming an advocate is absolutely paramount in the role that we do. It essentially is, we're oftentimes the voice for that patient when they're off site, or advocating the patient to be their own voice and to write down their concerns, discuss it with family and friends. We bring in the team and connect with outside organizations oftentimes. Next slide.
So what are these psychosocial distress and mental health concerns? Cancer providers really have many different ways that they screen for emotional distress and psychosocial concerns at different intervals in treatment. There are national standards that exist within the NCCN, and one of the metrics that is used in many different centers across the country is the distress thermometer. There are additional metrics that may be used. Some of these may be embedded within your electronic medical record, such as the PHQ-9, which is a validated, freely available patient questionnaire that screens for depression and suicide risk. Some health systems also have an additional social determinants of health screening metric, which can pick up on some of these other issues: transportation barriers, food insecurity, and other social or emotional concerns. Some of these distress screenings and mental health screenings will be managed by the care team. Sometimes they may be referred out. But it would be important as a takeaway to find out, what does your system do? What are some of the metrics that may be embedded within your EMR? Are there other research projects that the clinicians who are working at your center are adding on additional distress screening or depression screening, so that once we are screening for these issues, it's important to find ways to address it? Next slide, please. What are these distress symptoms? So this is by no means an exhaustive list, but this is a key list. If folks want additional information on distress symptoms and screening, you can go to the NCCN. They have a nice comprehensive guide going through all of this. They have one for clinicians as well as patients. What are some commonly identified emotional experience? And we're probably all familiar with this: worry, fear, feeling helpless, feeling things out of control, feelings of sadness that may persist into feelings of depression, being anxious, perseverating frequent thoughts of illness or death, concerns about what's going to happen with their illness, their treatment. Are they going to get better? Is this going to impact their quality of life? Is the cancer going to be curative? Or if for like our metastatic patients, how long will they be well? How long can they live with this as a chronic illness? So these are certainly distressing symptoms and some of the ways in which they present themselves. Next slide, please. So with these resources, so after the assessment has taken place, either through the EMR or in-house referral, or community referrals, and the distress is discovered, then what are the different ways that this can be moved forward? How can the emotional experience of the patient be then connected and make known to the different parts of the care team? And then what can we do about it?
We often receive our referrals in-house, community referrals, and then it's just, I think oftentimes our navigators are, where do we start? How do we, address these barriers? AONN Plus has a metric navigation toolkit where they've identified 35 evidence-based navigation metrics that demonstrate the value and sustainability of oncology navigation. The GW Cancer Institute has also created core competencies for non-clinical licensed patient navigators. And this allows us to understand where we fall in the continuum of care, what metrics would probably be best designated for our community or our practice. So please refer to them. There's other resources there, but these are two of the larger ones that will give us some verbiage and body around where we need to start. Especially new navigators are here to help and identify barriers, remove barriers. But really, where can we make that most impact? Is it barriers to care? Is it looking at turnaround times from diagnosis to treatment, or hospitalization, and non-compliance? So there are, like I said, metrics there that we can look at, and we really can help define where we can, so we can give quality of care over quantity. I mean, it can be daunting, but definitely doable.
Yes, next slide, please. So one thing I think is helpful for us to think about in terms of psychological and emotional wellness are helping our patients orient and think about what tools they have in their toolbox. What lessons may they have learned from facing adversity in the past? What are these external support networks that are available? Now, many of us in our professional roles and responsibilities, we may be asking this either through psychosocial screening tools or different components of what we do in our day-to-day practice, but just to kind of reorient us, because one strategy of kind of meeting as a strengths-based perspective and meeting people where they are is to come with an assumption that folks do have tools and resources, that they have gotten through tasks in the past, and that we can help bring forth and find resources within themselves. So they have it, they're bringing it, but maybe they need our help to kind of bring it to the fore. And for us to be sensitive to what we may need to do in terms of investigating what are our tools in our network of referrals and resources and people we depend on, other colleagues, other parts of the cancer team, maybe even external resources in the community. Next slide. So in terms of psychosocial support, there are some cancer centers that have some embedded services with them, and that would be something that you can certainly refer to. For those of you who may not have that, just know this may be a point of advocacy for you, for your system to have those types of tools. Some cancer institutions have embedded psychiatrists, special clinics, or referral pathways so that patients who experience significant distress can be evaluated and potentially addressed with medication and coordinated with the oncology team so that they are sensitive to what are some of the other concerns as they're navigating through treatment, mental health, et cetera. There can be embedded therapists within the network. Many of us also, even when we have those types of resources, they may not necessarily be able to cover everybody that is referred. So what are our external community-based organizations that may offer peer support or peer mentoring, or are there commercial or insurance-based providers that do have some specific training in oncology, but are embedded within the community that can offer individual, group, or family counseling?
And similar with nurse and non-clinical navigation support, navigation is an emerging field, and oftentimes our institutions does not have that exact title listed on a team member. So oncology nurse navigators, non-clinical navigators, financial navigators, even now insurance-based advocates provided by insurance carriers to understand your insurance plans, community advocates, oncology, pharmacy navigators. And, I often try to empower those that are within the community advocates, family members that are navigating the healthcare system. For those of us that are certified or looking for certification, looking, have a career and chosen this career path, we would follow metrics and such, and clinicians. But there are navigators within our community that we need to identify and support, so the patient has the most resources available to them at the time of treatment.
So communication and an impact on emotional health and well-being. So we know that there's really no right or wrong communication style. And we bring to ourselves in this work different ways that we say what we need to say, keep private what we need to keep private, right? So do our patients. And sometimes it's not something we think about in the way that we're navigating patients or assessing barriers or concerns or trying to figure out kind of emotional health or wellness and where we may need to step in and intervene is communication style. So just one other thing to kind of put in your toolbox of thinking through as you are talking to patients, figuring out what is their communication style, because that can have an impact on what types of questions they ask. Do they ask questions at all of their care team? But they may ask you as the navigator or social worker outside of the clinic visit. There could be folks who are more comfortable with a more direct style of communication. And where we may not be kind of as involved, there may be other folks who are a little bit more indirect, and we may provide some coaching and support to help them to be able to feel more empowered in the clinical visit and in terms of their cancer journey in general.
I'd like to share that oftentimes non-clinical navigators, and I would say the same thing for clinicians, but we are often at the forefront of meeting them and bringing them into the healthcare system. And by essence of navigation or being in this field, we want to address barriers and remove barriers. And that often could be looked upon as being problem solvers. And oftentimes, and we should revert to holding space, just being with the patient and allowing them to share their fears and their concerns and bringing it to the clinician for assessment and to be addressed. But holding space and being present in itself is a wonderful tool in which both clinicians and non-clinicians can do actively to gain trust and to understand what they're saying. And being present, it goes a long way. I've often had patients that say, you really understand, or you really did hear me. They need to be heard more than the solving, the idea of addressing barriers and removing barriers. And then once you know that, like I said, there's formal assessments that Celeste referred to, like the NCCN distress scale, where you can then drill in and know which provider, which resource and referral would be best outlined. But holding space and respecting and allowing that to happen and not solving it is a tool that we need to use more often, I found that I'm using more and more, as well as written form. I find that written form is very well used in the clinical space to confirm treatment recommendations. But when it comes to concerns and emotional needs, it's sometimes a little harder to write down. So working through with them on what are your concerns? Are there your children? Are there your work? What about your work is concerning? And then you can really open those lines of discussions with social work and with clinicians alike.
Next slide, please. And again, this is kind of hammering home what we've talked about, and this can be something that we are thinking through and how we are sharing to patients when they can reach out to support and kind of reorienting. There's nothing too small for them to share with us, a patient navigator, for those outside the system, internal system, but making sure we're behind the scenes communicating with each other to support that patient. Sometimes doing a little predict and prepare in terms of that needs can and do change at different points of the cancer journey, that there will be physical and emotional changes. There's nothing too small to let your team know about, and that there could be shifts in roles and responsibilities within your family unit, particularly for young cancer patients, but that we can be of assistance in trying to help them sort through and figure it out. And like Zarek said, sometimes holding space, because some of these concerns don't have easy answers. And sometimes it's just allowing the space for folks to be heard, honoring the resources, tools, and strengths and resilience that they have. And then knowing that we can maybe have a little bit of push along the way for one or two more tweaks to their trajectory of care. Next slide. So there are some other, we would be remiss if we didn't mention that in terms of emotional health, wellness, there are some tools outside of the more formal kind of therapy models of things that patients can incorporate it, frankly, clinicians, all of us can incorporate into our day to help us deal with the uncertainty of the future. COVID has certainly presented those challenges to us. For cancer patients, the uncertainty of the future in relationship to their cancer diagnosis. And as Zarek shared, something I didn't know, how the Calm app has a 6-month free for providers. And you can talk to us offline, but they have that option. So that would be a tool that is available not just for patients, but for us as clinicians as well. Next slide. And as we get ready to go to a close, but we would be remiss if we didn't bring about some resources that are available. Most importantly, do know that there are crisis resources available nationally around suicide, around mental health crises, either through text or phone call.
There's also cancer-specific resources, American Cancer Society, Living Beyond Breast Cancer, that do webinars such as these to help our patient population, and those listed there. And we are continuously challenging you as navigators and social work to look at specific population-focused resources, then really drill into what type of resources there are, whether they be support groups or retreats or these type of web-based ones, therapy for Black girls, inclusive therapy of color, and the list is there. And they themselves are a wealth of knowledge and really allow us to be focused on the individual needs. So by all means, resources are the key to navigation on the non-clinical end, and just allow us to be that more valuable for our clinicians and for our community.
Thank you. We just want to thank you so much for allowing us this opportunity, and turning it over to Stephanie.
Okay, well, thank you so very much, Celeste and Zarek, for this extremely informative and thought-provoking presentation. We are so grateful to you. I think at this point, we don't have time for questions and answers, but we were actually already planning to create for the audience a document which we'll post on our website at LBBC probably next week, that includes a list of resources, the ones that Celeste and Zarek just shared, as well as the ones that you're putting into the chat. And we'll also address any unanswered questions and answers at that time that you've submitted. So thank you for doing that and contributing to the program in this way. So on behalf of Living Beyond Breast Cancer, as well as the National Navigation Roundtable, I'd like to thank Zarek and Celeste for the important work that you both do every day. We're so grateful to have dedicated people like you out there supporting patients and being a part of this program. As I mentioned earlier, to everybody else, we will send you a link to the recording and the featured resources very soon. I want to again thank the National Navigation Roundtable for their partnership and recognize the Centers for Disease Control and Prevention for their support of this program. As a reminder, you will receive an evaluation link today. Please remember to complete it no later than September 29th. For those of you who request a certificate of participation, you will be emailed your certificate by October 20th. From Living Beyond Breast Cancer and the National Navigation Roundtable, thank you for participating in today's program and for the care you provide to people affected by breast cancer. We hope you will join us for future educational programs. Please take good care and enjoy the rest of the day.